Hello, everyone. Welcome to Chapter 7. Today, we're going to be discussing the joints of the axial skeleton. If you remember, that means everything in the center besides the pelvis. Always remember that when we're referring to the pelvis, we are referring to the two innominate bones on either side of the sacrum. The sacrum is a part of the axial skeleton as it is the last fused vertebrae along the spine. So always kind of like to drive that home just to distinguish the two. So let's go ahead and dive in here. Suture joints, those are the joint spaces that we find in our skull. They are structurally fibrous and functionally synarthrotic. So if you remember from last lecture, I reminded you that we needed to stick a few words on a Post-it note. You'll see those come back today, okay? So maybe grab that Post-it note or that note card and have it by you for this presentation, just so that you remember these specific words: synarthrotic, diarthrotic, and rearthrotic, okay? Now with the suture joints, these, especially here we see it in the skull, these are usually completely fused by age 2. We've probably all heard about a soft spot or how a baby's head is nice and gumby and soft until they're around 2. Well, that's because these are actually floating bones whenever the baby is born. And this is due to the fact that we have a baby exiting through the vagina, and we have that baby's head that needs to be able to be soft, be pliable. That way they are able to move and descend and rotate as they come out. So it's kind of amazing to see this progression and this fusion occur. And you will always have a pediatrician that will check these fontanelles or these areas where the sutures meet, just to make sure that they have fully fused by age 2. And whenever we're breaking down these joints, we always have to hit on the TMJ. You've probably heard of TMJ dysfunction or disorder, or yeah, I have TMJ pain. Well, it's the temporal mandibular joint. So this is where you have a synovial joint, which actually has a uniaxial modified hinge. What does that mean? Well, basically, you have a lot of movement, which will break down in the functional aspect, and so it has to be modified. Structurally, you have a disc, you have a buttload of major ligaments, a joint capsule to help support and give shape to this joint. And whenever we're seeking treatment on this structure, we're going to be affecting those ligaments and soft tissue. Functionally, it's diarthrotic, and this is why we see this modified hinge joint structurally. It allows for us to do a lot of various movements. For example, if you're sitting here watching this, I want you to do this with me. Move your jaw forward and back, side to side, up, down. Whenever you say words, your jaw has to move. We've all seen that. You get this elevation depression of your jawbone. You get that retraction and protraction. You get that lateral deviation, all happening within this joint space known as the TMJ. If we're looking down the spine, we can see that as a whole, we've kind of broken these down. We have 7, 12, and 5 of the respective vertebra, and they create this beautiful structure that we have. Now, we've talked about lordosis, kyphosis, and then the abnormal scoliosis. These happen naturally throughout these vertebrae, but now we're going to kind of break down some different things that we might see happen, as well as different structures that we might see. And this helps us to kind of apply it a little bit more, okay? So if we're looking at the spine, we have a lot of ligaments, and I love to talk about this because if you think about this spine, usually think about a chiropractor, which I love chiropractors. I refer out to them quite a bit, but there's also soft tissue here, okay? So we can affect the soft tissue as well as the structure. The ligaments help these joints stay up in their appropriate spots. And if they're functioning optimally, they help give us rigidity as well as function as little separation, or help us create space within those areas as well. So I won't make you memorize all these ligaments. That's for another day. That's an anatomy. But for today, I just want you to take a moment and appreciate how many ligaments you have in and around your vertebra. We see them anteriorly, posterior, laterally, in between. I mean, there's just so much going on to help us stay protected and stable as well as mobile. In between these beautiful vertebrae, we have discs. Intervertebral discs are made out of fibrocartilage. They have two little segments to them. Think of it kind of like a jelly donut. You have the nucleus and then you have that annulus fibrosus, okay? That nucleus, I want you to think of that as the jelly inside of a jelly donut. The fibrosis, that is the donut dough around the outside, okay? And this will help us visualize it whenever we talk about disorder and dysfunction later. Our discs actually account for 25% of our overall vertebral height, and each disc supports 80% of the weight above it, okay? 80%, isn't that crazy? So as you go down the joints, as you go down the vertebra, you have the cervical, you have the T-spine, the L-spine, each level supports more weight, and you're placing all that weight on the disc itself. So not only the vertebra, but the disc. So it kind of goes to show whenever we hear people say, yeah, I herniated a disc in my low back. Well, it kind of makes sense because that low back, those discs in the low back have to support a lot of weight, 80% of the weight above it, okay? So let's start up in the neck real quick and work our way down. But I've kind of discussed this occipital joint, there we go. Structurally, it's synovial, it's triaxial because it helps us be able to turn our head, move our head side to side. So structurally, it gives us the setup to have functionally a diarthritic joint. We have that flexion, extension, lateral flexion, and rotation all occurring between the base of our skull and C1, known as the atlas, okay? And then below that, we have C1, C2. And we've talked about how the dens pokes up through C1, off of C2, and helps us rotate left to right. So it makes sense that structurally, this joint would be synovial because we have so much movement, we have that ligament, but then we also have a pivot joint because it's uniaxial pivot around the dens, giving us functionally a diarthritic left and right rotational joint. You're like, wait, it only goes left and right, so why is it diarthritic? Well, that's a lot of movement. Think about, whenever it's functioning optimally, you can turn your head quite a bit. That's a lot of movement and a lot of responsibility within that space. In between the vertebral facets, we create a joint. And the facets, if you remember, they're almost like little pads. I always think of them kind of like the cup holders that your grandma has on the counter or on the table so you don't make a ring. Well, think about those facet joints. Think about those facets as little cup holders so that the opposite or the other opposing vertebra will have a nice cushiony place to sit, and vice versa. Structurally, these are synovial. Again, it's giving that cushion, giving it that soft space. But they're also non-axial plane joints, meaning that they're going to be able to slide and glide back and forth on one another. Functionally diarthrotic, because if you think about, especially if you're palpating, which means that I'm touching where a vertebra would be, and I'm kind of trying to move it, see if it moves, see if there's any stickiness. If I'm trying to dial something in, there's flexion within there. There's lateral flexion. There's rotation on those facet joints. There's also that gliding I mentioned. So it goes to show, whenever you're talking to someone who's thinks that their vertebra might be out of place or their back's out or something like that, we're looking to see if those facet joints are lined up appropriately, or have they gotten too much of a good thing and are a little bit rotated or flexed or whatever the case might be. So that kind of sets us up for thinking about applying this, right? as a chiropractor, as a physical therapist, as an athletic trainer, as an occupational therapist, you're going to be looking at these structures and you're going to know, hey, functionally, this guy, these facet joints, these vertebrae have a lot of play. They have a lot of movement. Is it moving appropriately? Starting back up in the cervical spine, I'm going to walk you through the different degrees of movement in each segment of the spine. Okay, so we've talked, about different things here, but now we're just going to take a moment just to appreciate the various levels of movements around the spine. Along the spine. So we're going to pair the C spine, T spine, and L spine, okay? So first of all, the cervical movement. We have a lot of flexion, a lot of extension, rotation, gliding, lateral flexion, left and right combination. There's so much that we can do. So take a gander, look at these numbers, just for visual, okay? 45, 70, 80, and then a lot more movements down below that. Let's compare that to the T-spine. Whoa, see that drop? We went from the 40s, the 70s, the 80s to 30s, 20s. Yeah, sure, we have gliding, we have lateral flexion, we have all these different rotational capacities, which is beautiful, and they're big and they're expansive. But do you see how our numbers dropped? The T-spine is naturally not as mobile as our C-spine, which it makes sense, right? Think about if you're turning your neck, you're making a big circle with your head and neck, that's a lot of movement versus in the T-spine where you have the ribs around there, you have your lungs, you have the organs underneath, like there's a lot of stuff happening in there. So maybe not as much mobility would make sense as we protect our organs, our heart, and so much more. So it makes sense, right? And then we go down to the L spine. There's a little bit more kind of movement, but not really. Like the numbers kind of stayed the same. And that's what we want to see. So whenever we see somebody who has a lot of mobility through their lumbar spine, man, their flexion's up in the 50s and, extension 40 or whatever the case might be, that means that they're not very stable down there, and it sets them up to being susceptible to injury. And then also the reverse of that. Think about somebody who's not moving the 35 degrees of flexion or lateral flexion 25 degrees in the T-spine. If they're not getting enough movement that we want them to have, and they're now in the 10s, the 15s, you can see how that it could impact up and down the chain, because each segment has to be able to do their part. If one segment's not doing their part, it actually affects above and below that segment. It's like an orchestra, it's like an accordion. Something has to move and the other has to respond. If it doesn't respond, we don't get as pretty of a sound or as pretty of a movement coming from that structure. Okay, I hope that makes sense. Again, replay this if you need to listen to that again, but just take a moment, appreciate how diverse your skeletal, axial skeletal system is here in regards to its mobility and degrees of motion. I love talking about soft tissue. I don't get to talk enough about it in this course. However, I can't not talk about this, okay? So we're gonna nerd out for a second, all right? Well, let's talk about what happens along the thoracolumbar spine. It actually has additional support and structures. Something called the thoracolumbar fascia. It spans from superior to inferior and laterally along the back. Superior to inferior, you see the spinous process of T12 to the spine of the sacrum. And honestly, I would argue it actually goes way up to the noggin. So right at the base of the occiput. You see this huge structure, this huge thoracolumbar fascia actually span all the way up to our occiput. Isn't that crazy? So literally the low back pain that somebody could be experiencing could be correlated to the fact that they've been experiencing tension headaches on the left side of their head and neck for the past 4 weeks or a month or 2 weeks or whatever the case might be, because that tension is kind of like an awkward t-shirt fit. If one side's kind of scrunched up or ill-fitted, or somebody messed up and it's not sewn on correctly, it's going to affect the opposite side because it's going to tug weird. Same song and dance here with the soft tissue of the back. And laterally, we see it go all the way out to the posterior, posterior lateral iliac crest. So basically the ridges on your hips. It's amazing what this structure can do. And I could nerd out about it for a while, but if you think about it this way, there's this big expansive layers of saran wrap that actually cover every muscle, every structure, every bone, everything that's on this backside, helping you have a little bit more force creation, helping you have a little bit more cushion, helping you have a little bit more support, but then also helping you feel more stable, secure, and so much more. Like I said, I could talk about that for a while, but hopefully that plants a seed about the thoracolumbar fascia. The other thing I want to talk about is on the front side. It's the abdominal aponeurosis. And there's a whole rant I could do about how six-pack should disappear whenever you inhale, and that the six-pack doesn't really show strength. But I'm going to save that for another day. If you'd like for me to dive into it, shoot me an email, and I would love to do that. But this aponeurosis, if you remember me explaining it before, is basically a big tendon. I have my mentor, Dr. Kathy Dooley. Her best explanation, she's like, think of it as a big ass tendon, layers upon layers upon layers of strong connective tissue that runs from the inferior aspect of the sternum to the pubic symphysis. So we're talking about, right at breast height, all the way down to the base of our pelvis. And then laterally, it goes out to the anterior superior iliac crest. So the anterior side of that hip crease that we see at the top of our hip bones, of our pelvic bones. And this one's really fascinating because the aponeurosis actually helps to create the definition that we see in a six-pack. Think about somebody who runs cross country. So they have low body fat percentage, or somebody who is doing bodybuilding or going to a bodybuilding competition. We see those like individual six-pack to like whatever, 18-pack abs, right? And we see that definition. Well, that's technically, yes, that is pumped within the muscle. And that is, those muscle fibers coming through, yes. But what creates that little line in between is the aponeurosis, okay? And why, I'm not going to dive into it too much, but why we need to be able to have these six-packs disappear whenever we inhale is because, again, a muscle needs to be able to stretch and contract in order to have power, and also in order to have this aponeurosis function optimally as well. Whew, okay. Next up, let's talk about scoliosis. We kind of talked about it earlier, but I want to hit it again because there was a little bit of confusion on the exam. Scoliosis is structurally or functionally occurring. And what do I mean by that? Structurally, scoliosis can occur, due to deformity of the vertebra. So that means that the bone itself, whenever you were born, or whenever you found out there's actually a change in the structure of your vertebrae, of the bone, versus a functional scoliosis is actually due to a muscle imbalance. Or think about tight muscles on one side and lengthened muscles on the other side of the spine. That functional can lead to a structural deformity over the time just due to the property of creep that we've discussed before, and how being in one set position can actually change and deform the bone. So ramifications of this: a contracture or tightening of muscular on, say, one side of your curve, you will have a stretching of the musculature on the opposite side. And if that's the case, if we see that, then dang, we can affect that scoliosis. even if this functional tightening and lengthening has occurred due to a structural deformity, we can still impact pain and improve mobility and movement and quality of life if we're targeting and just thinking about these aspects. And then it can also cause a leg length discrepancy. This could be a result or the cause. So somebody could be born with a true leg length discrepancy, and then it actually affects the spine and it has to laterally deviate in order to keep you level and upright. Or you could have that functional imbalance where one side strengthens, one side straightens or stretches, and then that's what causes the leg length. So it can go either way. All right, let's apply it some more. So all of these have been kind of applying, and I hope that you're having fun with this. This next one I call the 4 S's, excuse me. And so as the name gets bigger, the problem gets worse. If you remember that, you're doing pretty good. I actually have personal experience with this. My dad had several of these, and I'll kind of use him as an explanation just to kind of dive into these concepts as we go. So spondylitis. Itis means inflammation. If you ever see that. So like tendinitis, inflammation of the tendon, spondylitis, inflammation of a vertebra. Basically, that means that the bone itself is hacked off, inflamed, and is starting to experience that discomfort and inflammation condition. Then you have spondylosis. Losis means breakdown. So spondylosis means that we have a degenerative arthrosis or breakdown between the vertebral bodies. Arthrosis meaning a chronic bone disease. So you'll kind of see the bone actually start to break down. It wasn't just inflamed. Maybe it started off that way, but now we've progressed. We're having degeneration and breakdown of the bone. Okay, so spondylitis, spondylosis. Next up, spondylolysis. Yeah, say that 4 times fast. Just wait until the 4th one, then try it. Okay, spondylolysis. So this guy, it's interesting because it's actually a pars defect or a fracture. If you remember, pars is that structure seen right here between the superior facet and the inferior facet. And you'll see it right here. It's also called I think it's the spotty dog collar or the Scotty dog collar condition or injury, because it looks like, you know, the Target mascot, that little dog with the red collar. Well, it looks like a puppy dog, and there's your red collar. Okay. If you see it, you see it. If you don't worry about it. But it always helped me remember it. With this one, there's actually that degeneration that we've talked about, but then we have a fracture on top of that. Usually this occurs in adolescence. Like for my dad, he experienced this in a football injury. He was in high school playing football. He got hit wrong in practice and actually fractured this space. This is sometimes caught. Back in the day, it wasn't caught very much like with him. They didn't know about it until he went into the military, and then they're like, oh, hey, did you know that you had a fracture here? And that kind of helped to explain his back pain, because there was degeneration because of that impact and fracture. And so they start to have that snowball effect of pain and more. Because next up, then we have spondylolisthesis. So we had lolysis, now lolisthesis, okay? Like I said, as the word gets bigger, things get worse. Sad but true. This is the complication of that lolysis, okay? This is where there's actually anterior slippage of the vertebra, like of the vertebra, excuse me. Woo. There's anterior slippage of that vertebra. And this is just due to that vertebral degeneration, that inflammation, probably the instability around the tissues due to such things, and the pars defect. Most common, you're finding this at L5, S1. Because think about it, we're going from, you know, L3, L4, L5, all of these structures that move, to S1 that is concrete and fused together, okay? Kind of creates this chance for a rigid structure versus a flexible structure. The flexible structure is going to become more mobile. So, like I say, those were the 4 S's. As you get bigger in the word, more bad juju, okay? More complications, more impact. Next up, we have spinal stenosis. Yes, this is another S, but it's completely different than the ones we were talking about. This is actually the narrowing of the vertebral foramen. I encounter this in many humans that come into my office. And in fact, science has shown most of us by the age of 40 will have some sort of stenosis, just because now we're biped and we have gravity and those implications on our vertebral spaces and discs, especially in this day and age. And we sit a lot, we have inflammatory diets and so much more. It can impact this. Now, some of people, they're able to get shots and do things like that, and it's able to correct this or help them, I shouldn't say correct, but help them have a good quality of life and they do not have to have surgery. But for many people, they actually have to have decompressive surgery where they widen the intervertebral foramen, which just in case you forget what that is, that's right here. And they remove a portion of the lamina, so a lambdectomy, just trying to widen out this gap. Okay, because what it is as this vertebral foramen contracts and narrows, it's pressing on this nerve so that the clients get, or the patients get, referral pain to wherever that nerve leads. It's not fun at all. And honestly, it's one of those, it's just not fun, but we do have solutions for it. There are different things to do. But like I say, it is very common, especially in this day and age. Okay. All right, the next one that we're going to talk about is the disc issues that we see. With this one, you probably will know somebody, or maybe you yourself have experienced this condition. It's very, very important. It's very prominent in our society. I've actually experienced this myself. So the first stage of a disc pathology is usually protrusion. This means, and I'm going to use our jelly donut example, that nucleus, that jelly, bulges out into that donut dough without rupturing it, okay? It's kind of like whenever you're a little kid and you knew that there was a jelly donut, so you kind of squeezed it a little bit. It was like that first testing, oh, is it in there? Yeah, this is that testing period. This is the protrusion where there's a little bit of pressure and it's going laterally and deviating into that fibrosis or the donut part of our jelly donut. Next, we have a herniated or prolapsed disc. We've most commonly heard it as herniated, but that's basically where that jelly has now pressed into that dough pretty extensively, okay? It's not just a little bit. Now we're really pressing, really squeezing that jelly donut, and it's really pressing into that donut space. Extruded, this is bad news bears. This is where that jelly donut actually ruptures. It pushes all the way through the dough. And this is like whenever the little kid kind of presses on that jelly donut a little bit too hard and it starts leaking out the sides. It's pushing into the epidural space. Yes, this is the same epidural space where you see epidurals given for pregnant women or for surgical cases. Then this is really bad news bears. This is sequestered. This is where everything is on the outside. This means that that jelly donut has been squished so much that everything pushes outside of the discs. This is where we have to have lumbar fusion surgery because they have to go in there, clean all of that up, remove that gunk, and insert a bone graft in to help with that voided space. Because if it's completely sequestered, that means that we no longer have any padding. Like somebody just squashed or like somebody with a boot just stepped on that jelly donut and it's now everywhere and we have to get a cleanup crew, okay? This is the end of that disc's life. We have to have that disc or space in between vertebra, otherwise there's significant pain, loss of function, and more. So lumbar fusion surgery is there for that individual. Now, if you're experiencing, especially herniated, these are perfectly rehabable. It's going to and get, like for me, if I was treating somebody, we're going to be working on intra-abdominal pressure management. We're going to be working on mechanics. We're going to be working on postural positioning and getting that person familiar with maybe their body again, because chances are they've been actually altering and impacting their movement strategies for quite some time. So lumbosacral joint, this is that L5S1 that I talked about before with that hypermobility and spondylolysis and spondylolisthesis. This is a basic facet joint, but again, it's where that L5 movable vertebra sits and then has a disc and then has that fused sacral space. Functionally, it's a plain joint because it has that ability. And then structurally, or excuse me, I actually flipped these. Structurally, it's a synovial plain joint. Functionally, it's a diarthrotic. We have that flexion, extension, lateral flexion, all these different things, but we have to be super careful because we don't want it to have too much mobility in that space, because that's usually where individuals will start experiencing pain. I know I'm one of those people. I can raise my hand here. Maybe you can too. And it's very important that we keep that space healthy. Now, let's apply this just a little bit more, okay? We're gonna pull on our 3D glasses. Whenever we have, you'll see this in the shoulder as well, but sometimes there's rhythms where different joints actually correlate and respond to one another in order to have a specific movement occur. So there's a relationship between the sacral position, so the position of that sacrum in between the pubic or the pelvis bones, the innominates, and the lumbar spine and how it moves. For example, whenever you have a posterior pelvic tilt, that means that you're tucking your tail under like a scared dog, you have lumbar flexion. Versus whenever you have anterior pelvic tilt, lumbar extension. Your pelvis rotates to the right, your trunk will either go with it or rotate to the left to keep your trunk stable, and vice versa. So we see that? It has to respond in kind. Sacral base angle. So this is something that is created between the sacral base and the horizon. Normally there's about 30 degrees, but if we are abnormally tucking the tailbone under or sticking our bum back, we'll kind of see that angle change. Now, I love this picture just because I kind of make it fun of it every single time. Nobody knows the perfect neutral. Like everybody's neutral is different. And I use quotation marks if you could see me here. But we try to find a space where we can load appropriately and have minimal pain if there's somebody in pain, and find what normal is for that person, but it's relatively 30 degrees. So clinical applications for this sacral base angle is kind of like what I was talking about. If we have abnormal straightening of the spine, so that means that you have taken out some lordosis and you're tucking your tailbone under and you're kind of waddling like a little old man, you're going to have increased pressure on the lumbar vertebral body. That means that the space that where the spine like sits one on top of the other, that big piece of the vertebra is going to have additional pressure on this. This could cause possible creep deformity on specific areas of that vertebra. And if you do the opposite, where you stick your butt out like a model, so you have what I call model butt, and you have that increased lordotic curve, then you might have some increased pressure on the facet joints. Remember our grandma's little coasters that she has on the table? We don't want to set something super big on that because we don't want to damage those precious things on the table. So same thing with our spine. We want to make sure that we don't have too much pressure there, because that can actually cause creep deformity on those spaces as well. So it's all about a balance, right? My business is actually called Positively Balanced, because I find that in the body, you know, we're never really perfectly balanced, but we want to get in a space where we can effectively move. And especially whenever somebody's experiencing pain and discomfort, we're trying to find that happy space, that place where we can start to heal, start to recover, and start to re-optimize movements to where we can expand our movement patterns, and so much more. So again, all about a space or a balance, tucking the tailbone under, sticking it out, whatever the case might be. But especially whenever we're talking about the pelvis and the lumbar spine, that's exceptionally true. So I hope that you enjoyed this presentation. We dived into a lot. This is my first time presenting this online, and I am so pleased to do so. I hope that this started stimulating some thoughts in your brain. I will provide some additional resources for you guys if you would like. I love to see this visually. So if you would like that, please shoot me an email, and I'd love to send you some additional resources. All right, everyone, have a fantastic week, and we'll chat next one.